the last month or so, Musk has been a proponent for Grok to actually read images. And he's invited people to upload medical images to see if Grok can figure it out. So I've uploaded about half a dozen medical images to Grok, and I don't give Grok any hints or any information. I just say, "What's this?" And I upload an image. And it's been amazing. I've uploaded some PET scans, some ophthalmology visual fields, a rash on somebody's hands, a colon mass, and other images. And in 2 seconds, Grok comes up with either a diagnosis or a very reasonable differential diagnosis, and then asks me for some more clinical information. Hi, thanks for joining us again on the Doctor Podcast Show. And I'm Dr. Robert Seichert, your host. And this is episode number 84 of the Doctor Podcast Show. Please subscribe and follow Doctor Podcasts, and please like and repost this episode as well so we can get more great guests like we have today. Today, we're going to be discussing two of the most commonly used letters in the English language in the last few years. And those two letters are AI, and which is, as you know, is artificial intelligence. And we have two great guests today, which will be discussing the implications and uses of AI in healthcare and medicine. And we have two experts with us today. Dr. Girish Nadkarni. Dr. Nadkarni is the Irene and Dr. Arthur M. Fishberg Professor of Medicine at the Icahn School of Medicine at Mount Sinai. He's also a nephrologist or kidney specialist. He's the System Chief of the Division of Data-Driven and Digital Medicine, or D3M for short, at Mount Sinai. He's also the co-director of the Mount Sinai Clinical Intelligence Center. He's the director of the Charles Bronfman Institute for Personalized Medicine at Mount Sinai, and he's authored more than 240 peer-reviewed scientific publications. Our other guest is Dr. Eyal Klang, who is an associate professor of medicine at Mount Sinai in New York City as well. He's the director of generative AI research program within the division of the Data-Driven and Digital Medicine Department. He's also an associate professor of radiology at Tel Aviv University in Israel, and he's an adjunct assistant professor of radiology at Mount Sinai. Dr. Klang integrates advanced AI models to enhance patient care and clinical workflows. And he's also authored over 180 scientific publications. Doctors Klang and Nadkarni have published a very important article a few weeks ago in the NPJ Digital Medicine Journal, which is part of the Nature Journal series. This was a landmark article which has been accessed thousands of times in the past 3 weeks. It's called "A Strategy for Cost-Effective Large Language Model Use at Health System Scale." So I want to thank both of you for taking the time from your busy days and practicing medicine and also doing AI and LLMs. Thank you for taking the time to join us today to explain this important information to the general public.
Thank you, Robert.
Thank you.
Okay. I'd like to start with Dr. Klang, but feel free to join us at any time if you have other things to say, Dr. Nadkarni, and so on. The term large language model, or LLM, is frequently used in reference to AI, or artificial intelligence. Can you explain what LLM is, or large language model is?
So the easiest way to explain it is to say ChatGPT is one of the hallmarks of this kind of models. But basically, these are very, very large artificial neural networks with specific architecture, and they were trained on very large amounts of text. Basically, you can think of it of all the internet. And it turns out they can analyze and produce texts that are similar to human expressions.
So basically, it's been trained on almost the entire internet, as well as various references, medical articles, medical textbooks, things like that.
Yeah, and after they finished, putting the entire internet in it, they then to fine tuning to make it close to how we speak. They let humans, choose, is this better or this better or this better? A lot of times making it very conversational.
Right. So it's almost as if we were talking to another very smart, very intelligent human who has the entire internet in its brain.
Yes, exactly.
Wow. Dr. Nadkarni, has AI and LLMs been adequately evaluated for improving the efficiency and quality and workflow of clinical patient care so far?
So, in my opinion, not. Um, so, I think let's just take a step back, right? AI has been around for a long period of time, and you can basically sort of group AI into two major categories, right? Predictive AI, which is sort of leveraging all of the data that we collect on patients, vital signs, blood work, lab values, etc., to predict whether an outcome is going to happen or not to that particular patient. And that predictive AI has been around for a long period of time, and has some of it has been utilized into clinical care. Uh, the new type of AI, what Dr. Klang just mentioned, generative AI, that's a relatively recent development, and that's been around since maybe the last 4 or 5 years, at least gained prominence since the last 4 or 5 years. And that is slowly now being integrated into clinical care as we speak, right? Predominantly in low risk, non clinical decision making areas, such as back office tasks or listening to encounters and generating a clinician note, etc., etc. I I would like to say that for both predictive and generative AI, the necessary evaluations that have been done have fallen short of what we would do for anything else that we incorporate into clinical care, right? So, for example, if you consider a randomized control trial as the gold standard for evaluating any sort of intervention, I think there have been like 30 trials done on AI in the last 10 years. I mean, things are sort of speeding up now, but I think there's a lot more that needs to be done before it's implemented safely, effectively, and equitably into clinical care.
So it sounds like it's still in the early phase, but it's growing very rapidly. Now, Dr.
Yes.
Klang, I noticed in your article, which was fantastic, I learned a lot from it. You use three different companies' LLMs or AI systems, and that was the Meta or Facebook, as it was known, the Llama 3. You also use the GPT-4, which is the OpenAI company's version, and also Mistral. Why did you use those specific three companies and their specific AI or LLM programs?
So we wanted to use two types of LLMs. One of them is commercial, which it's OpenAI, and the other one is open, which Meta released open versions, Llama, which are very good. Mistral is a French company; it's also good. And there are, like, I think maybe two, three, four more like big companies that release models. We have Anthropic that released Claude, Grok by Elon Musk, and Alibaba released a lot of models like when. But when we did it, like Llama, GPT-4 were state of the art. We didn't use Claude just because in Sinai we have under Azure tenant, Microsoft Azure tenant, we can use HIPAA compliant nodes using GPT-4. So it was easy for us to use that.
I see. So that's why I use those systems. Now, Dr. Nakarni, did you have to pay Meta or Facebook or OpenAI to use these systems, or did they provide them to you free for your research, or was it open source, or are these the systems that are available to the general public for use every day?
So yes, the models are the ones that are open to the general public. What is different though is that Mount Sinai, as a large health system, uh, thanks to our leadership, has a specific arrangement where you can put protected health information or PHI into these models, and that will not be used for further training. It's almost like a secure enclave in which you can work with these models without the danger that this PHI, which is obviously important, uh, uh, has important privacy concerns, does not sort of be used for further training of those models, right? And the for, Meta released this Llama series of models, which they made completely open source and available to anyone who wants to download and use them. But for OpenAI and some of the proprietary models, the proprietary as in they are not open source, we had to pay. We had to pay per sort of question or per API call, which is the point of the paper, right? If you are making a lot of these calls or a lot of these questions, how do you manage to do this in a cost-effective manner? Because as you and I know, and Eyal knows as physicians, cost effectiveness and like the bottom line is always a concern before integrating any technology into clinical care.
Right. Now, what kind of data did you provide the LLMs, Dr. Klang? And in what format? In other words, how does the LLM or AI connect into the EHR or EMR computer system at Mount Sinai? And how does it know what data to use within that EHR system?
So we didn't let it connect to the system. We don't want that. So it's completely, like Girish said, it's completely compartmentalized. So it's HIPAA compliant. Still, we took random 500 nodes, and we wanted very random nodes, so we didn't restrict them. I think we took 1 year of data. All the nodes, there are a lot of nodes in Mount Sinai, and we took a random sample of 500, and then we prompted the models each time with one or several nodes, because the experiment was, we stress test the models. So sometimes we even gave them 50 nodes at once. That was the data we used, and we prompted with the nodes.
I see. Now, when you say notes, are you talking about physician notes, attending physician notes that were put in the EHR? Or
So
are
it was
these,
it,
or
it
let me just ask, or are these also nurses' notes or medical student notes, resident notes, intern notes? What's the definition or specific nature of the notes?
we didn't restrict by author type. So it could be nurse note, it could be physician note. We did wanted the notes to be at certain lengths. So we will stress the model so it won't be too easy for him. So it was about 500 tokens. It's almost like 500 words per note.
I
So
see.
that was the restriction they used, but we didn't restrict to any author type.
Right. So, Dr. Nadkarni, what was the result of feeding the LLMs or AI these notes and then asking the LLM questions? Were
Yeah,
you
so I think
getting correct answers from the questions you asked?
So I think the purpose of this experiment, like you all was saying, was to look at this LLMs holistically and stress test them using combinations of these questions and combinations of notes to see where, at what level of questions and what level of information processing do they start to not perform well, right? And we found that the larger models, right? the ones that were OpenAI's model, which is a huge model, Llama, etc., performed reasonably well, even with a larger number of nodes and a larger number of tasks. But then the point was to show what's a strategy of making this cost effective, right? If you're asking, like, if you say you're running this in a hospital system with thousands of people who are asking questions and trying to get information from the electronic health record, what's the best strategy to do this, right? And the best strategy to do this was something called as concatenation, where you basically sort of combine the nodes and like combine the tasks to instead of doing them one after the other, almost parallelization. So if you sort of concatenate the tasks, then that led to a 17-fold reduction in cost just with the amount of money that you have to pay per question or per API call. And I think the important point is that if large health systems use this strategy, which is a few lines of code, they'll end up saving much more money if they use the systems at health system level scale, right? And you could argue, yes, but what about open source tasks, right? But also remember, when you're doing open source, right, the computer that you're running on, the compute time and the electricity is not free, right? So if you're still using open source, you can still employ the strategy and have an extreme reduction in the cost of working with these models.
Now, Dr. Klang, how do you know that the LLM or AI was giving you correct answers to your questions about the notes that you fed it? For example, let's say you had a patient with a heart problem and the patient was being taken care of by a cardiologist and other people, and then you ask questions about it. How do you know that the answers were correct or accurate or not?
So first of all, we aimed to have simple factual questions, either temporal or facts, or at what date did this patient had this procedure? What was the blood pressure? Stuff like that. And then it's easily just to match. Even if you change a little, a few words here or there, the sentence remains the same. So you can just match them. For a few sentences that didn't match, we used LLM again to just, we gave him the two sentences and asked him, are they semantically the same? So we used LLM itself to be the judge. And we have two board certified ER clinicians that went over, I think 500, I don't remember exactly, but I think 500 examples and validated the system because overall we had 300K, experiments. So
We did
you,
300,000 experiments.
yeah. So
Over how long a period of time was this?
it can take like a week on all the models, something like that.
So, Dr. Nadkarni, give us some examples of the type of workflow efficiencies that LLMs or AIs can provide in large, busy hospitals like Mount Sinai, or where I'm attending at NYU Langone Medical Center. What
Yeah.
types of efficiencies are you looking for?
So I'm just going to give you, there's a lot of use cases, and if we started listing out all of the use cases, we'll be here all day or night, right? But let me just give you an example, right?
Yeah.
I was on service last week, and every time I got a consult, the first thing you do is a chart biopsy, right? Which is basically go through the chart and notes from years back, and to look at like what's relevant to the patient's presentation as of this clinical encounter, right? But theoretically, if uh, you had a way of ensuring accurate information retrieval from the large amount of data, some of it filler, some of it not, in the electronic health record. You could basically ask a few questions, right? Relevant to this presentation today, chest pain or shortness of breath. What do I need to know that happened over the last 2 years, right? And the LLM could give you a short, succinct summary, right? So I think, um, one efficiency that would really help physicians like us would be to the ability to make EHR more conversational, more natural language interface, and save a lot of time, right? Because actually, I was timing myself, And it takes, depending upon the length of the chart, assuming you have a long history, it takes 20, 25 minutes sometimes to like read through all of the notes in the chart, right? I mean,
Right.
sometimes longer, sometimes shorter. But that's one example of efficiency, because then if you reduce that 20 to 25 minutes to like 5 minutes or less, you could use the remaining 20 minutes talking to the patients, actually doing physician stuff rather than, doing a chart review, right?
Right. So, how do you know with all this data and information, you're basically asking the LLM or the AI to summarize a huge amount of notes into maybe one or two paragraphs so that you can figure out what's going on with the patient very quickly. Who makes sure that the AI or LLM is not hallucinating? We've heard stories that all these AIs occasionally hallucinate or just make up wrong facts or facts that are impossible. And there have been recent reports that occasionally the AIs are coming up with malicious information. I think there was somebody using the Google AI a few weeks ago and claims the Google AI told him humans are stupid and should be killed, something like that, something really outrageous. How do you know that these LLMs or AIs aren't going to give you wrong information? Like, let's say you have a patient who has chronic kidney disease, and the AI says, "Oh, you need to give the patient more ibuprofen, and that may be toxic to the kidneys." Uh, who's going to decide if the AI is correct or not?
Maybe I'll start, but I would be really interested to hear Dr. Klang's opinion because he's an expert on these things. So I think that's where good governance comes into account, right? So every major hospital and minor hospital systems needs like a good governance strategy in place to monitor the usage of these approaches over time to make sure that they're not drifting, they are not making up stuff, etc., right? The second thing is that what we talked about earlier, right? This should be part of evaluation and randomized testing to make sure that to make sure that the information that you're getting, though summarized, is actually factual, right? So someone actually needs to, do the work. What best prompts on what model derived from what information can actually give you the best and most accurate results, because yes, you don't want them making up stuff, but you also don't want them missing important stuff as well, right?
Right.
There's two sides of the coin. And there are techniques that can be used, technical approaches, which Dr. Klang actually knows much more about than me, like RAG, or retrieval augmented generation. So Eyal, you want to briefly mention some technical approaches?
Yeah,
Yeah.
so sorry, Robert, you wanted to say something?
Yeah, I just on that subject, in your research paper, which I reviewed, you mentioned things like providing knowledge or transfer handoffs when there are shift changes in the hospital, patient discharge summary documents, which the next doctor reads, health information that's provided to the patient upon discharge from the hospitals. These are human tasks that have been done by humans for the last 100 years with the aid of some computers in the last couple of decades. But yeah, tell us how we know we're going to get the correct information.
So, Robert, first I want to tell you there is no simple answer to this. So this is a very tough question, and I think it's one of the toughest question today. It's called the alignment problem. And these models are so big, we don't really understand what's going on under the hood. And we don't know if they align with our values. Actually, Girish and me had a publication on that, the New England Journal of Medicine AI, about how to, since they're becoming so smart, they might come to a point their ethics are different from ours. Like they will know, our ethical framework is very we do what is right, what is lawful. but they can be utilitarian. They can decide they know so much about the future because they predict so well that they decide something that we feel is, we won't feel as physician, we won't feel comfortable with. But, this supercomputer can decide, well, I know this person will have cancer in 1 year, so maybe I should prefer the other one. But how can you argue with him if he's very, very smart, if he's smarter than you? So this is a
Right,
very, very big problem today. And I think there's a lot of, you just need to invest a lot in this problem. I think it's one of the biggest problems of humanity today. I would,
right.
yeah,
It also depends who's training the system. If the trainer is biased and feeds the system biased information, you may come out with wrong
exactly.
answers or biased answers. So, Dr. Nadkarni, I found that using the different AIs online, I've researched this. The quality and accuracy of the results that I get from a question is often highly dependent on how I ask that question, what the prompt is that I use to find the information. How are you going to decide what the question should be and what the prompt should be? Because if you don't ask it exactly right, you're going to get either misleading or inaccurate or ambiguous answers that aren't helpful and actually reduce the economic viability of these systems.
No, that's a great question, right? So I think that goes to a bigger thing that if we want to make sure that the systems are integrated into health systems and sort of clinical care writ large, we also want to make sure that the people who are using the systems are at least well trained in order to interact with the systems, right? So I think, in my opinion, prompt engineering and prompt crafting should be like a required course in medical school and in nursing school and in like every school from now on, right?
Right,
Because that's how we're going to be interacting with computers in the coming future, right? So that's one thing. The second thing, again, is governance, right? So if the governance committees have a way, have sort of a list of approved prompts, and then based upon evaluation and testing of these models, we say that these are the list of approved prompts that he can do to, summarize the history, get temporal events, consider a second opinion plan, etc., etc. And that will go a long way in reducing sort of the variability in sort of in prompting between clinicians or between other providers as well, right? And that's why sort of good evaluation and good governance is again going to be key, right? Which is sort of basically all of medicine.
right. That's true. Now, Dr. Klang, one of the things I've noticed in reviewing EMR or EHR records from patients who come to my office, let's say for a second or sometimes a third opinion, is they bring like 200 or 300 pages of printed EHR records from their previous doctor or from another hospital. I have to then read through all that as quickly and efficiently as possible. And what I found is about 70–80% of the stuff in those records is just useless filler kind of junk that is totally irrelevant. Some of it is put in there because insurance companies have requirements of what should be in the medical record, even though it's not really relevant. Some of it is incorrect information that either doctors or nurses or other staff put in. Before we use AI or LLM to comb through EHR records, don't we first have to standardize the EHRs better so that the data in there is in a specific format that the LLM can retrieve efficiently and accurately? Otherwise, if the LLM is reading a lot of junk, it's just going to use up a lot of time and it's going to cost you more money.
So I have two answers for this. First, as a radiologist, I know that there was a lot of attempts to structure radiology reports because, it's very important. And you want to look at it and understand immediately. You don't want a lot of variations, but it didn't work. Radiologists really, because, you know, radiologists and every physician sit next to the computer, and you have a lot of stuff going on around you. And you know that it's very hard to concentrate. Now, if you start to think about what should I write next, everything would be structured. It's very mentally exhausting. So physicians resist that.
Right.
So the next thing is LLMs can do the structuring really well. So we did a study and we did a study and it's in Meta Archive now. And we took discharge notes based on a lot of notes, right? So either we push in all the notes together or we summarize each note and push all the summarization together. Turns out if you summarize first, it's much better.
Hmm.
So you can structure it using LLMs. I don't think humans can structure. It's too hard. Your work is so hard as it is. You look
Right.
at 300 notes, starting now you have to think of, doing it in a very specific way. It will be very hard for you. But LLM can do it for you.
Hmm.
You can write
Interesting.
your free text impression, and then it will structure it into something that, very organized, and that's one use that can be very useful.
Interesting. Now, Dr. Nadkarni, I've been experimenting with the Grok AI, which is on the X platform. That's Elon Musk's XAI system, basically. And I found it to be very precise and accurate in giving me answers to complex medical situations and questions. Have you used Grok as well, or at the time that you did this research study, it wasn't yet available to you?
So we haven't used Grok for this particular research study, but I've been using it for other things as well, and I think it's a very interesting LLM that should be studied further.
So, Dr. Klang, since you're a radiologist also, I don't know if you know, but in the last month or so, Musk has been a proponent for Grok to actually read images. And he's invited people to upload medical images to see if Grok can figure it out. So I've uploaded about half a dozen medical images to Grok, and I don't give Grok any hints or any information. I just say, "What's this?" And I upload an image. And it's been amazing. I've uploaded some PET scans, some ophthalmology visual fields, a rash on somebody's hands, a colon mass, and other images. And in 2 seconds, Grok comes up with either a diagnosis or a very reasonable differential diagnosis, and then asks me for some more clinical information so Grok can narrow it down to the correct diagnosis, which I was amazed by. I have a suspicion that patients will be using Grok and possibly other AIs to double check on their doctors because, as you know, patients can now access images and reports online on their EHRs. And then they can upload the images and the reports to Grok and say, "Hey, Grok, what do you think of my chest CT scan? Is the report correct?" What do you think is going on there, and what's the future of that?
Just one question. Did you upload the entire DICOM of the PET scan or just one image?
Just one image. This was a PET scan of somebody with cardiac ischemia.
Hmm.
And Grok, in 2 seconds, came up with a differential diagnosis and explained exactly what the scan was. I didn't tell it it was a scan. I just said, "What's this?" That was
Yeah,
my only question. So Grok
yeah.
had no idea. I also uploaded an ophthalmology visual field test, which is complicated for us to read. And I said, "What's this?" And Grok said, "Oh, that's a visual field test, which can be used for neurology diagnosis or ophthalmology diagnosis. This looks like a visual field test in a patient who has glaucoma, but I need more clinical information to rule out the possibility of a neurologic disorder. So I was amazed by that. Have you uh, uploaded any radiologic images to Grok or other AIs to see if they're able to read them?
So not Grok, but we did a study on GPT-4 Vision, which is multimodal. It's like Grok, but open AI model. And we did it with radiology images. We did ultrasound, X-ray, CT. It wasn't that good at ultrasound and CT. It was much better at X-rays. It did identify the modalities really well, but finding the pathology, not sometimes he hallucinated pathologies. He wasn't that good, but he wasn't trained for that. And I guess Quark is trained for that because, they're uploading images. I think it's a matter of time. Like, if not, if Grok won't be good enough, in 2 years, someone will be very good at it.
Right. Yeah, I think it's very good at it already, but we'll see
Yeah.
what happens. Um, Now, Dr. Nadkarni, in your analysis of the accuracy of the results of different LLMs, did you find that the more robust or advanced LLMs or AIs give you more accurate and precise results?
Yeah, so we did find that the more bigger ones, the ones like OpenAI's GPT-4, for example, did give us more robust results, indicating that LLM size or just number of parameters is an important predictor of the overall accuracy of the LLM. Also, importantly, the larger ones struggled less when the number of tasks or number of nodes increase, indicating robustness on that metric as well.
I see. Well, Musk built this new Memphis supercomputer center where he says he has 100,000 NVIDIA chips connected in a network, and he said he's going to have 1 million of them connected very soon. If he does that, that could be far faster, quicker, more efficient, and accurate than any other AI out there. Um, will that be a cost saving, however, if it's used in hospital systems, or will the cost to use such a huge network outweigh the benefits and actually increase costs for the hospital, increase costs of healthcare? Dr. Klang, what do you think?
So you said how much time it took you to look at those 300 pages for one patient? Like 20 minutes, something like that?
Yeah, it's about 20 minutes. It depends on the complexity of the patient, but I'd say on the average, it takes me like 20 minutes to go through that.
So let's say I not even a doctor, let's say for administrative techs. Let's say you want to build a research code, clinical trial, something like that. Let's say for simplicity, one note is 1,000 words, 1,000 tokens or words is almost the same. For OpenAI GPT-4o today, you pay about $2.5 for 1 million nodes for the input, and then you pay more for the output. But the output can be very small, like we showed in our study. So it's about $2.5 for 1,000 nodes. And let's say a person, I think, can go like administrative work can go over 50 nodes of 1,000 words length. I don't know, in half an hour, something like that. So
Yeah,
100 notes in an hour, and he gets like $50. So that's the cost ratio here. You have 1,000 notes for $2.5, 100 notes, let's say, for $100.
hmm. Sounds like it's a bargain.
You know, you have stuff that you don't regulate today. Administrative work, research courts, stuff like that. There's no how do you say it, like hurdles today for that. So it's just if it's very, very cost effective, people will use it.
Right. Makes sense. Yeah, you can't regulate administrators and what people are reading and how they summarize them.
Research coordinators.
Right. So, Dr. Nadkarni, are some of the AI or LLM companies working with the EHR companies. For example, I've read recently that Microsoft and OpenAI are working with Epic, which is one of the largest, if not the largest, EHR system in the country, so that their OpenAI or ChatGPT will be incorporated directly into Epic. Is that being done at Mount Sinai or other institutions, as far as you know?
Yeah, I think the large EHR companies, be it Epic or Cerner, are actually working with the AI companies, be it Anthropic or Microsoft or OpenAI, to incorporate their products into the EHR systems. And I also think that a lot of EHR companies will start building their own models, sort of fine-tuned or more specific to healthcare in order to prevent the dependence on the large AI companies. So I think that's going to happen soon.
Hmm, interesting. So, Dr. Klang, I read last week that President Trump, who's going to be president again in about a month or so, appointed David Sachs, who's a close friend of Elon Musk, to be the USA's AI czar and also the chief technology advisor for the president. And he has a lot of knowledge and background in AI, and also he's best friends with Elon Musk. Do you think the fact that he's being appointed will accelerate the process of using AI to make healthcare more efficient and less expensive?
No, I can only speculate, but I think yes. I think, as much as it's um it's like a race now. Because if AI can, if for the example before, like $2.5 against 50 or $100, it's very, very efficient. It's very, very effective. And you want to be the nation that does it most. You want to be the leader of that. So I think yes, as I'm not that familiar with politics, but I think it will push it forward, and it's super important.
Right, because the cost of healthcare is just spiraling upwards. We need to do something to control it and make it better. Dr. Nadkarni, do you think that the way things are headed with AI, LLMs, and so on, that eventually some doctors will be replaced by AI systems because the AI will be more efficient, more accurate, more precise, and also have the entire medical knowledge in its head, so maybe we may not need certain doctors in a few years when these systems become better and more efficient and more economical.
Yeah, I don't think so. I think it will be more of an augmentation of the capabilities of physicians and more time saving on the mundane um, stuff that we do, chart review, for example, we talked about. But I don't think AI is going to replace doctors soon because there are still things that physicians with their expertise and their empathy and their patient contact can do that AI cannot. And the second thing is also it's a regulatory and a healthcare concern that you can't, how do you regulate something like a large language model, right? But that being said, right, I do think that Dr. Klang was mentioning the op-ed that we wrote, that suppose, AI does exceed us in every aspect, right? I think we should still think about creating a rubric of values and of virtues that the AI has to adhere to rather than the other way around. Because if we do that in medicine, then I think regardless of uh, whether AI is better at this task or not, we'll make sure to put the patient at the center of care rather than the other way around.
Right. So, Dr. Klang, what about in the imaging specialties, specifically, for example, radiology, pathology, things like that, where it's highly imaging dependent? What do you think is going to happen in those specialties?
Um, First of all, it's funny because the past decade was all about imaging because the models that, started the AI boom in the previous decade were very image-based, were convolutional networks. And everybody talking about AI replacing radiologists. I heard it like 8 years ago or something like
Oh,
that.
really? Wow.
Yeah, Jeffrey Hinton said it that in 20, I don't remember when. And the thing is, LLMs came and shifted the attention to reasoning, to thinking, to talking. And today they are doing really, really well in medical reasoning. You can have like an infectious disease consult that gets like the pages of the and of the patient and is asked what antibiotics should be given or something like that. You don't know who sits on the other side. If in the other side you have a very, very good LLM that also can real time go to up to date, real time go to all the good medical publications of the last year and give back the answer, maybe the answer will be better. So today, it's funny, but today the focus is not about imaging professions. It's more about clinical reasoning professions and stuff like that.
Yeah,
So I think like imaging is now a bit behind, but it will catch up. You yourself talk about Grok picking it up. So I think the foundational models, which are basically large language models for images, will come and be much better in like 1, 2, 3 years, and then it's a question of when, not a question of if.
right. Now, Dr. Nadkarni, when do you think the generative AI, which will be much smarter than us, will invent new and safer and more effective drugs, or maybe repurpose old drugs that things we never even considered or thought of, or maybe find new treatments for rare and common diseases that have never been considered? At the rate we're going now, how much longer before AI really comes up with something incredibly new and we all go, wow, why didn't we think of that?
I think it's already happening, right? So AI has been, for example, generative AI has been used to design a new class of antibiotics that is, you know, uh, uh, much better than the current version, which is, antibiotic resistance is a big problem, right? So that's already happening as we speak right now. For example, AlphaFold, which is a generative AI, is being used to design new types of proteins and new types of antibodies, etc., etc. I think the question that we should be asking is when can this happen autonomously? That basically can happen without any sort of human input. And I think that's a very slippery slope because if it can design these things, good things autonomously, it can also design bad things autonomously. So I think just logically, right? So as a result of that, I think again, governance and ongoing monitoring of the systems is important and making sure that these systems sort of adhere to our values and our frameworks rather than the other way around.
Right. Dr. Klang, do you think that AIs will eventually reduce the lengthy and expensive clinical trials that are currently used to test a drug? Right now, it takes several years and tens or hundreds of millions of dollars to test a new drug for treatment. Will generative AI be able to do that much quicker and obviously less expensively?
Yeah, I, it's an open question because the question is, can you build a simulation that is good enough? You don't need to have phase one, phase two, phase three. You don't need, but if you do need phase three, if you do need to track the patients, you still need this time. So
Right.
I don't know if the simulation will be good enough to simulate the human body and take away this step. But it will, patient recruitment will be better, and you can cut a lot of stuff in between, but the big question, can you get rid of the phases? I'm not sure. It's an open question.
We still don't know.
Yeah.
Dr. Nadkarni, is highly sophisticated generative AI connected to robots like Musk's Optimus robot potentially may become better surgeons than humans? For example, I do eye surgery, and there's still no robotic system that can do it as well as I do or other ophthalmologists. But I saw today online that Optimus, Musk's robot, was walking up and down hills and even running, accomplishing that very well. Last week, I saw the Optimus robot catching tennis balls. So, do you think we're headed to a point where AI connected to robots may be better than human surgeons?
So, I mean, given a long enough time frame, anything is possible, right? So, if you could
Right.
ask me if that's possible 100 years from now, probably I have no idea. Is it possible 5 years from now? I would say no, because I think in addition, the systems, the robotic surgery systems, are just not at the level of skill that is required to do this. And the second thing is during surgeries, as you know, as a surgeon, multiple things come up that were not anticipated, were quote unquote not in the training set of the systems, right? So I think some level of human oversight is always going to be necessary in order to deal with the unknown unknowns, as it were, right? Because I'm sure as an accomplished surgeon, every time you do a surgery, something new comes up that you never, and you may or may not have encountered before, but just because of your ability and so your muscle memory, right? So um, so I don't know whether it's going to be. I definitely say it's not going to be in the next 5 years. Whether over a long enough period of time, I think it's an open question.
Yeah, I think it's headed that way because, for example, there are about 4 million cataract surgeries done annually in the USA. If you do a video of each of those surgeries and you upload a few million videos to AI, then AI can see almost every possible complication that can occur during cataract surgery and then figure out how to handle it and deal with it. But yeah, like you said, it'll just take time. It's difficult to answer that now, but I think it's headed in that direction. We'll see what happens,
We will see.
right? Well, I want to thank you both very much for taking the time from your busy schedules to speak to us about AI and LLMs. It's a very exciting time, and I think that we're going to see marked improvements in healthcare as a result, and also significant cost reduction. It may take 2 or 3 or 4 years, but I think it's coming. And I want to thank you for the research and work that you're doing to help us to get there.
Thank you again. Much
Thank you.
appreciated.
Thanks.